Hello and welcome to this session. My name is Dr. Ehtasham Junaid. Let's wait for people to log in. We'll give them a couple of minutes. Well, not even, well, give them a minute. So start logging in. Can you all hear me? That's the important thing. Can you hear me? Can you see my screen moving around? Very good. If you can see it, tell me, type something in the comments section so then I know that I have an engaging group of people. Let's just give it a few more seconds. While people are logging in, just want to say a few things. Firstly, thank you so much for the amazing response we've had with these live sessions. And I'm very grateful for all the kind feedback, and we just want to make it even better every single time. And a special treat for those who are joining us live, which is a bit more effort than watching it recorded maybe, is that we'll have a separate session at the end of this session in a breakout room, a bit like Zoom meeting room type thing. Uh, and we'll post the link of that shortly in the comment section. So this link will not work right now. As soon as this session is finished, uh, we'll move into that room. And because that session is not recorded, so you can ask us anything. We can do some vivas or board exam preparation type question and answering, and we can sort of get to know what people want to learn, so we can then prepare our future training and lectures, etc., according to that thing. So that's a kind of special treat for those who are joining us live right now. But this session right now on the Facebook live stream is recorded, so you can revisit this at a later stage as well if you want to clarify. And also, one more thing, a lot of people have contacted us regarding our CT head course. It's now available to be booked online. So make yourself visit the website. So excellent. So we've got a good number of people logged in, so we'll make a start with this. Now, Tuesday session, as you know, is for cervical spine trauma. Thursday session is for CT abdomen and pelvis. Now, we've specifically given you radiopedia cases because they're far easier to give you access to them. The limitations are obviously you can't window as well, and uh, not all the scans have everything that of every single sequence and every plane, but I think they do have an excellent teaching point, and that's what I want to give you here. So remember from last week, we talked about the importance of looking at everything else on the cervical spine, because if there's a pneumothorax, there's a big hematoma blocking the airway, there's a foreign body, if there is other things, for example an NG tube or an endotracheal tube in the wrong place, they will far quickly cause significant harm to the patient, or cause morbidity than a broken cervical spine. So cervical spine can be immobilized, and that's why I take my time with the cervical spine. If the people are rushing me saying, what is it, what is it, what is it? I say, well, wait, I'll give you a report, and they just have to immobilize the patient until we give them a report. In fact, it's the last thing I report. I report on a full body trauma. I'll report the head. I'll look at the cervical spine for any obvious major problems. I'll report the body in the primary survey, and then we'll come back to cervical spine. So as I said, look at everything else. Let's look at in this patient. We've got a patient who's got trauma, road traffic accident. Make sure so in this we are looking at the endotracheal tube. It's in the trachea. Sometimes they can go in the wrong bronchus and cause collapse of the lung. So that's, if you've got enough images, do look at that. That's the NG tube. Again, it's going down in the esophagus. They can get coiled up and cause aspiration for the patient. Also looking at anything else, and can you see any abnormal hematomas or any collections? And just looking at this particular slice, this image, what do we see? Something very, very abnormal. We can see this large prevertebral soft tissue type density, and this reaches right to the airways. Now it's quite dense, so it's almost as dense as muscle, if not more. What can be in this context of trauma? This would be a hematoma, a prevertebral hematoma. This patient had obviously had some significant injury to the cervical spine. This big hematoma. This hematoma can quite easily compress the airways and cause a patient to die that way. So I'm obviously clearly very worried when I see this. So we also need to look at other things. So let's look at the axials. As I said, look at the axials if you have them. In fact, you will have them. And this is a CT head that's come with this scan. And I can, for those who are familiar with CT heads, will be jumping out right now. Now, type your answers in. What do you think is going on with this CT head? Is this normal or abnormal? Tell me now. Come on. You got, just say normal or abnormal. If it's abnormal, what's abnormal about it? This is a very, very abnormal scan because we've lost the gray-white differentiation. The brain just looks very homogeneous and very globally of low density. Now, what can cause global low density is global ischemia. It may be, this is sort of global hypoxic brain injury. We can see some layering of blood in the occipital horns. It's an area of dependent blood, and you can even see some blood in the pons as well. And the brain looks a little bit swollen as well. So let's go further down. This is really, really abnormal, right? Large prevertebral hematoma. Now you can see this hematoma can quite easily compress the airways. And so that's something telling me this is a significant injury and this patient's not going to do well. So let's go back to the sagittal, which we have here in this case. Is we only have the soft tissue windows, but that's enough to tell us the abnormality. So as I said, starting from top to bottom, right? So the occipital condyles, right? So these are occipital condyles. The occipital condyles should be articulating with C1, but they're not. Okay, so not on this side. I can see some flecks of bone, so this is likely to be an avulsion, and even on the other side. So this is a complete dislocation from the atlanto-occipital dislocation. And so this is also called craniocervical dislocation. And in fact, when I report, that's the first thing, well, one of the first things I say in the report is normal craniocervical junction, if it is normal. Now, this is a very, very significant injury because most of these patients do not make it to the hospital. Craniocervical dislocation, effectively, you've decapitated the bony parts of the brain, of the head. So the head is no longer attached to the rest of the body via some sort of bony stabilization. So it's essentially going to be very floppy. And therefore, and you can see now it all makes sense where you've got this big hematoma, you've got the brain, which is of completely low density. If you look at on the sagittal, look at the cervical cord. It goes this way and then kind of makes a very sharp turn that way. So again, it's because this head is now floppy, it can move here and there, and therefore there's a significant risk to damage of the cervical cord as well. And we can see some flecks of bones. These are avulsion fractures that's come off the C1 here on this side. And if you go on the other side, you've got some flecks of bone avulsions taking place there as well. So the take-home point, look at the vertebral soft tissue, and oft you will not see very many of these cervical dislocations. This is bad news for the patient. Okay, so let's move on to the next case. And we can see in that they've shown us the gap between, sorry, I'm a bit slow with this. We can see that because of craniocervical dislocation, we've got this gap which is way too big, right? You know, 2.8 centimeters, should only be a few millimeters. So this is the Bayesian, this is the dens, and that, is in itself very, very abnormal. Okay, so craniocervical dislocation, and it can be the other way around. So you can have, because this is no longer held together, in other scenarios, you can get the actual dens poking right in as well. Right, so let's look at the next case. Pedestrian struck by car, unresponsive. Okay, So now you can see this. I just flick through this case. Is it normal or abnormal? Firstly, as I said, always look at. So we've got limited things in this radiopedia case. We've got bony, sagittal, and an axial, and coronal. So we've got, but we don't have any soft tissue windows. But what I would be always doing is looking at the ET tube, and it's going in the airways. Another thing to look out for, remember, is look at the sternum. Don't forget the sternum. You can get sternal fractures. Don't forget the ribs for any fractures, any pneumothorax, which you can see quite well even on a bone window. This guy's got quite a dilated esophagus. Very odd. Anyway, that itself can be associated with other problems. Right, we won't go into that. So let's look at the bones. Make sure you look at everything else. So you don't want to miss somebody's broken jaw. Right, so clivus, Bayesian, right, is the gap. What's the distance between these? It looks reasonably okay. Let's look at the occipital condyles. Okay, occipital condyle C1, C2. Right, that's okay. And I can see some flecks of bone by C1, but we'll come back to those. But the C1, C2, sorry, the occipital condyles and C1 articulation is normal, so the craniocervical junction is normal. Let's look at C1 now. So we can see some flecks of bones, okay? So when you see flecks of bones, that tells me that something's pulled off the bone, right? So an avulsion of some description. And then we can also see the transverse process of C2. There's a little fracture through the transverse process of C2. And right next to it is where the vertebral artery goes through. So really, assess to see if the fracture line goes through the transverse foramen. I don't think it does in this case, but obviously I'll look at the other planes as well, on the axial particularly. So as I go across, you can see that this gap between C1 and C2 is also way too much. It should only be about 2 or 3 millimeters. You can allow a bit more in pediatric population, but in the adults, this is way too much. So again, I'm worried that there is a C1, C2 subluxation, and you can see C1 and C2. This gap is again way too much. So these the ligaments which hold this together, have obviously gone, and we can see these tiny little flecks of fractures. So again, this tells me avulsion fracture. So you can't see any big chunky pieces flying off, but you can see that some ligaments have torn off, and particularly these would be the transverse ligaments which hold C1, C2 together. Let's look at this on an axial. We can see that this gap is way too much. And as we scroll further, so the ring of C1 itself is okay. So there's no Jefferson fracture in this case. But as we go further down, so this is still C1, now C2. We're coming on to C2, and we can see these tiny little flecks of bones. So these are ligaments which are attaching C1 to C2. So you can see these ligaments have pulled off, and therefore there is subluxation of C1 between C1 and C2. And there's a fracture also going through the transverse process. And I'd really pay attention to make sure it doesn't enter the vertebral foramen, the transverse foramen, in which the vertebral artery traverses. If that is the case, then you're worried about a vertebral artery injury because you can get dissections, then you'd get an angiogram. Again, also look at everything else. The bones are okay. And I go back to sagittal. And now assess the rest of the spine. Look at the anteriorly. Is there any widening? Now, it's very common, as I said last week, to get artifact around about this level. So this is 2, 3, 4, 5. So 2, 3, 4, 5, 6. C6, well, C7, T1 junction, you tend to get a lot of artifact, right? And you can see it's a bit blurry, and most images you will see today, they tend to have this. And it's to do with, a number of reasons. It could be because of the jaw, it's the way the images are taken, but for some reason you get a lot of artifact around the C7, T1 junction. But we're looking for any gaps which are widening, and we can't see any. This little fleck of bone, may be normal, probably is, because it just kind of degenerative type changes, but I can't see any distraction injury at the moment, and there's no widening posteriorly, and then also any changing of gaps here. Because sometimes you can get injury which is not bony, so you won't see any fractures per se, but you'll see widening of the joint spaces. So the ligaments have gone, and it can be just as unstable as a bony injury. So that's the other thing you're looking for. We can see there's a lot of degenerative change, but the main thing that we're worried about is this. There's the C1, C2. This gap has gone way too much. This gap between C1, C2 has increased. These two should be sitting on each other, and you can see, look at that. C1 is not really articulating very well with C2. In fact, there's a tiny little fracture going through here as well on C2. And then the C1, so coronal is very good at looking at fractures through the lateral masses. Okay, yeah, often you won't see them very well on a sagittal, because the fracture orientation is the same orientation as the sagittal view. So sometimes you'll go through the fracture and you won't see it very well. Again, looking for any pneumothorax and everything, and hematomas. But in terms of bones, this is very good also at looking at the occipital condyles. So these sort of certain planes are much better at looking at certain things compared to. So don't stick to just one, look at every single plane. Right, let's look at the next case. I want to get through as many cases as we can through the course of these sessions. So again, more traffic accidents. Okay. So in this case, we have the sagittal, axial, and coronal bony recons. But again, as I said, always look at the bones. Always look at, excuse me, at the lines and tubes. It's been a long day. Right, so look at everything else. For any hematomas, pneumothorax, etc. Blah, blah, blah. So let's just cut to the chase for now. As I said, any fractures involving the cranium, the base of skull. So let's look at this systematically. Right. So is there any craniocervical dislocation? So let's look at the occipital condyles. Assess them very well. Good. And hang on a minute. You can see a lucent line. Let me just show this to you a bit better. Okay, so you can see that sort of lucent line where I'm this sort of thing there. So I'm worried that there's a minimally displaced fracture through the occipital condyle, and for you to break your occipital condyles, the force will have to be axially. And then as we go across, but it's still articulating, so there's no dislocation. They're still articulating. Very good. Okay, so now let's look at C1. Okay, because this is the hotbed of injury, right? Here is where you find most of the fractures in cervical spine, and the higher the injury, the more damage you can potentially cause to the cervical cord. I mean, any injury anywhere on the cervical spine can be significant, right? So let's look at C1, right? So as we go across, transverse process of C1, we're going across. So anteriorly, there is no abnormal gaps, nor is there any gaps between the Bayesian. So we go scroll across. C1 itself is okay. Let's go across. Oh, hang on, what's going on here? So there's something not right in this transverse process of C1. We'll come back to that, okay? So park that, because remember, you can't see everything very well on every single plane. Okay, C2, let's look at C2. That looks okay. Let's go across on C2. Very common place to get fractures is here of C2. And then at the pars articularis, the AKA, also known as the hangman's fracture. Right, so once we've done that, now stop at this point, because I just want, my tip is look at C1, C2 together and really scrutinize them after on the sagittal. After you've done that, now let's look at all the alignments, right? Is there any abnormal alignment elsewhere? No, I can't see any listhesis. I can't see any opening up of any joint spaces. Okay, nor can I see it posteriorly. And then let's look at between the spinous processes. There isn't any. Okay, but I can see, obviously, we can see this thing jumping out at us, these spinous process fractures, right? So we've got multiple spinous process fractures. Uh, and so we'll come back to these. But essentially, you know, it's just an unstable injury. So unstable injury would be if you've got a three-column injury. Three-column injury is the columns are the first column is the anterior two-thirds of the vertebral body. The second column is the posterior two-thirds, and the third column is the posterior, the neural arch. And so we've got neural arch injury, but we don't have any injury elsewhere. So if you've got involvement of two or more columns, it's classed as an unstable injury. So this is only sort of single column injury. So we only have one column involved. Therefore, this is going to be stable. This part of the injury, anyway. Well, we're going to revisit the thing that we'd seen higher up, and we spotted earlier on. We've got this occipital condyle fracture, which you can see very well also on the axial. And then let's look at the ring of C1 very well. Good. And then C2, body of C2. And we can see this little kind of fleck of calcification. It's well rounded. There's no sort of inflammatory change around it. It doesn't look like a fracture. It's probably an old ossicle, not even ossicle. It's just an inflammatory post-calcified tendon area. So nothing to worry about because it's nice and smooth and round. No sharp edges, so it's not a fracture. But this is a fracture. Okay. We don't have the axials further down, but we can see that the fracture is definitely involving these spinous processes. And let's look at the coronal. Again, the important teaching point here is this, that you can see the occipital condyles very well. And the coronal is very good at, again, looking at the cranial-cervical junction, C1, C2. Okay, so you're looking for any widening of the C1, opening up of C1. We can't see that. We can see this fracture very well. And this little bony thing, calcified thing we'd seen, very well rounded. It's not a fracture, nothing to worry about. It's a bit of calcification in the tendons, the transverse ligaments, not tendons, sorry, ligaments, transverse ligaments. And then, as we said, on the sagittal, we had seen something not quite right on the transverse process. And as I said, the coronal is very good at looking at fractures involving the transverse process. And we can see there's fracture involving the C1 transverse process and also C2 transverse process. So they jump out at you because remember the fracture is in this direction, almost, not complete, but it's in this direction, in the sagittal plane. So when you're doing a sagittal plane anyway, you'll miss them. So really look for fractures in this orientation on the coronal. Just for a bit of anatomy, these are the mastoid air cells. And so if you start seeing a pacification of the mastoid air cells, really look for base of skull injury, which is not an uncommon finding with somebody who's got a neck trauma. So do look out for those sort of things in this scenario. Okay, so one more case. I think we can do one more case. Let's move on. Let's see what's going on. I'm going to give you a few moments to look at this scan and start sort of giving me your ideas of what's going on. Okay, so as I said, let's do it systematically as well, as I said. So we've got all the planes in this case. So soft tissue windows, I'm looking for, is there anything blocking the airways? Any hematomas around the vessels, grossly okay. Going further down, there's no upper mediastinal hematoma. Let's look at, is there any pneumothorax? No. Right. So let's cut to the chase. Again, on the sagittals, I'd be looking for any prevertebral soft tissue thickening, and there isn't, this. So as I look here, there's some soft tissue thickening here, right? So I'm thinking, hang on a minute, this should be nice and thin, and it's a bit dense. So I'm worried, or I need to interrogate this further, right? If this was a very young patient, this doesn't look like a very young patient. You can get, lymphoid tissue here, but this is right in front of C1. So I need to investigate this further, right? So let's look at these on the sagittal views. Again, on the sagittal views, I'd be looking for, again, everything else. Make sure, they haven't got a fractured mandible. I'm really sort of reiterating these things again and again because you don't want to miss those things, any bony fractures of the ribs. So let's go through this systematically, right? Look at this. So let's look at craniocervical junction. Craniocervical junction, how is it? It's okay, but I can see something's not right. There is a fracture in the lateral mass of C1. Right, let me show this to you. Okay, it's an interarticular fracture. It's involving the actual articular surface. Okay, let's go on the other side. And in fact, you can see the fracture going through the ring of C1 and involving this lateral mass as well. So for something for the C1 to fracture like this, again, you've got to have axial injury. You've got to have axial pressure, directly hit your head from top. This can. So that my suspicion is right. You've got the soft tissue thickening, and it makes sense when there is a fracture involving C1. So let's not stop there. Let's look at everything else. So I need to interrogate this further. C1 is, you can see the ring of C1 on the entirety on an axial. So we look at that properly. Let's look at C2. As I said, look at C1, C2 together, as in individually, but really assess them together as well, and scrutinize them because you'll see a lot of injuries in C1, C2. Right, so I can see that looks okay. Now let's just stop at this. Can I see any malalignment elsewhere? No, I mean, you can see a lot of arthritis going around here. These little things are, well corticated, so these aren't acute things. These aren't sort of acute teardrop fractures or anything like that. This is all degenerative, but I can't see any major slips. Let's look at these posteriorly. No, nothing going on. Let's look at the facet joints. I can see the facet, again, very important. Look at the facet joints to make sure there isn't any distraction, any subluxation. Arthritis, osteoarthritis going on, but not really anything else. Let's look at the spinous processes. No, not really. So the main thing I'm worried about is the C1. So let's look at C1 on the axial. Okay, let's go to the top. Again, don't forget everything else, okay? Yeah, don't forget everything else. You've got the mastoid A cells. You can easily look for any basal skull fracture. But we're interested in C1 because we've seen a fracture of C1 on the sagittal, and you can see that there is a fracture here. That's C1, a fracture there, and a fracture posteriorly there. So the C1 is like a ring. So you won't break the ring in one place. It'll break in more than one place. And often, this is what we call a Jefferson's fracture. Diving board injury, diving injury, dive right head first and hit the head onto the shallow pool. So this is what you'll end up getting, a Jefferson's fracture of C1 fracture. Other thing, advice is when you're looking at CT heads, make sure they'll image C1 and they'll image part of C2. 10 to 15% of elderly with head injury will have a fracture of the cervical spine. So do look out for fractures as well. So let's just look at everything else. What I would do is look at every single vertebra in turn. And so what I would suggest is that if there is any abnormalities that you can see. So for example, specifically we mentioned last week, look at these facet joints. Is the burger okay? This is the burger. You can see arthritis going on, but I can't see any fractures. So scroll down, and also paying attention at the transverse foramen, ensuring that there is no fracture through it. Do not forget the cervical, the central canal, to ensure there aren't any bony fragments causing cord compression. We can see these osteophytes and things, but there isn't any acute things within the cervical cord, the cervical canal. And remember, as I said, the coronal is very good at looking at um, cervical junction as well as the lateral masses, and you can see very easily. I mean, the patient's moved a little bit, but you can see very easily that see the lateral mass fracture of C1, fracture here, there, and here. So it's kind of starting to open up. You can see this gap has widened up, and when you do an X-ray, the open peg view, it's essentially what we're looking for. This is essentially what this is. This lateral mass on both sides has moved apart. It's moved in both. Is distracted away on both sides, and you can see it very well on the coronal as well. So we'll stop right there on the cases for the cervical spine. We will continue these next Tuesday. We'll cover more of the other injuries on cervical spine. I hope you're finding this useful. If you've got any comments on things, questions, post them now on your comment section. But actually what we'll do now, as we promised earlier on, is we'll move on to the Q&A session for the next 15 minutes or so into our breakout room, which is a bit like Zoom. I think we've posted the link earlier on. We can do that again now. Let's post the link now. Here, you can ask us questions. We can go through things again. That bit is not recorded. What I'm speaking now is recorded. So you can sort of feel more comfortable with that. So no question is a silly question. Take care. And okay, remember, please, please, please spread the word. I hope you enjoyed these sessions. And if there's anything you'd like us to cover, please let us know. Follow our page so you can actually receive the updates. If you have any questions, feel free to post us. And also, please, can I request you all to leave us a little review on our Facebook page. If you like it, give us a good rating. It encourages us. We do this out of the passion for teaching, staying behind after work.